Alright, here's the second video about using loop diuretics to treat a patient with fluid overload. So we ended the last video talking about finding the working loop diuretic dose. And so this involves finding the dose that's going to hit threshold, and that threshold will result in natriuresis. Okay? And so, like I say, with outpatients, I just ask them, hey, that dose that I prescribed, does it make you pee more a few hours after you take it? And that's sort of a crude, non-scientific way to assess this. Or if they're adept at measuring home urine volume, you could do that. And of course, for inpatients, you can keep close tabs on urine volume after each loop diuretic dose. So let's assume that you've found the working loop diuretic dose. So maybe you had to double the dose or escalate the dose until you found the one that works. Our next question is, are we actually achieving net negative fluid balance? So keep in mind, for the patient with fluid overload, they have a net sodium excess. In order to fix them, we have to put them into negative sodium balance. So we need more sodium to leave the body than enter the body. And so if we're using loop diuretics, that's going to come out through urinary excretion. So we need to have more sodium leave the body through urine than enter. Okay, so how do we achieve a net negative fluid balance, or how would we at least assess that? So number one, for inpatients, we can assess their fluid intake and fluid output. If we see that the urine output exceeds intake, at least that's evidence that more fluid is leaving the body. And so also keep in mind that there's some insensible losses, maybe 750 even to 1,000 liters of mostly hypotonic water a day. And so using urine output and strict ins and outs is one way to monitor this. Also, the change in weight, I feel like this works best for outpatients who have a reliable scale. You can tell them to weigh themselves every day in the same manner. So maybe with just underwear, or if they're willing to do it naked, but not with shoes or snow boots or something like that. For some reason in the hospital, monitoring daily weights is always a challenge because typically bed weights are used, and I find those to be pretty unreliable. So standing weights is another way to monitor whether a patient is actually in negative fluid balance. So this is ultimately what we're trying to do, to get them into net negative sodium balance, okay? And so this is why we put limit sodium intake first, because if you think about it, we could have found the correct loop diuretic dose, okay? And then maybe the patient is taking their torsemide twice a day and it's causing a good amount of natriuresis, but they could always eat or overeat what we're losing in the urine. They could ingest more sodium than is being lost, and you could actually see weight gain rather than weight loss. And so you have to have some way of monitoring whether you're actually doing the job you set out to do. Also, this has happened a couple times in the hospital. Like, I've been presented patients, and let's say diuretics are being administered and the serum creatinine increases. Someone may tell me, oh, well, we think this is due to overdiuresis. Maybe because the timing between the loop diuretic and the rise in the serum creatinine, but further investigation into maybe intake and output or the weight change actually shows the patient has gained weight rather than lost weight, and that they've been fluid positive day by day rather than losing fluid. And so that would argue against so-called overdiuresis or volume contraction as an explanation for the rise in the serum creatinine. So whenever you're using loop diuretics, you need to ask yourself, are we doing the job? Are we actually in net negative fluid balance? And so if you're not, this is where you get into, bolus versus infusion therapy. And so either one is effective. They've been shown to be essentially equivalent for getting a patient into net negative fluid balance. And so once you found the working loop diuretic dose, the only thing you got to do after that is adjust the frequency. Do you need to give the dose twice a day, or 3 times a day, or 4 times a day? I don't know. You just have to do it whatever it takes to achieve net negative fluid balance. And obviously, this is why we put limiting sodium intake first, because if they're restricting sodium intake and fluid intake, that makes your job easier here on the back end. So I wish I could say that this is always easy, and so now it's time to introduce some things that are going to make your life more difficult when treating a patient with fluid overload. So we're back to looking at the pharmacokinetics and pharmacodynamics of loop diuretics, and look at this graph here. So on the y-axis we have sodium chloride excretion, and then at the bottom we have time in terms of hours. What I'm showing you here is that with repeated bolus dosing of loop diuretic, from the first dose to the second dose, you actually see a decrement in the amount of sodium chloride excretion. This is assuming we're even hitting threshold, right? You can see that with the first dose, there's this first dose effect. Let's assume we hit threshold and we get a great response. Even with the second dose, there's a little less than we got with the first dose. And you can see if we started a furosemide infusion, there's actually this slow decrement in sodium chloride excretion over time. So why would that happen? So shown differently, so here's another graph showing the same phenomenon. So we have sodium chloride excretion on the y-axis, we have time on the x-axis, and look, each spike here represents a loop diuretic dose, and you can see it says dose under it. And look, with each repeated dose, we see a decrement in the amount of sodium chloride that's actually lost in the urine. So this has a name, and it's called the braking phenomenon. It's almost like your body's putting the brakes on how well it responds to loop diuretics. There's another thing worth noticing on this graph. So notice that after each loop diuretic dose, we actually had a drop in the sodium chloride excretion. That's what's represented by these areas here. And so I colored it red to represent what we call the post-diuretic sodium chloride retention. So after each loop diuretic dose is worn off, remember, as long as we're at threshold, we're going to have net sodium loss, we're going to have natriuresis, and a high urine output. But after that loop diuretic dose is worn off, the body is now more aggressive at retaining sodium and chloride compared to what it was before we exposed the body to loop diuretics. This is called this post-diuretic sodium chloride retention. Clearly, this could be a problem if we're trying to achieve net negative fluid balance. So clearly this represents a problem when treating these patients. If you just focused on the early phase, you may feel like you're doing a good job because your loop diuretic seems to be working. It seems to be resulting in net fluid excretion. And if you give it enough time, however, there's going to be less bang for the buck, and the body's adapting in such a way that the dose of loop diuretic is less effective than it once was. Oh, and then in between each dose, there's more aggressive sodium chloride retention. And so anyone who's practiced medicine long enough or treated patients like this know that it's frequently a cause for readmission, right? Recurrence of edema, shortness of breath, pulmonary edema, essentially some sort of adaptation or resistance to the loop diuretic that seemed to be working just fine when the patient was just in the hospital. So let's explore that, because you're probably wondering, why on earth is this happening? So these are the main factors that are responsible for diuretic adaptation, the braking phenomenon, and resistance to diuretics. Essentially, remember, this is a maladaptive physiology, and essentially when we're talking about heart failure or liver failure, we're talking about decreased effective circulating volume. And so the kidney is sensing low perfusion, and so in the setting of heart failure, it's low cardiac output. In the setting of liver disease, there's peripheral vasodilation and low perfusion, and then other baroreceptors are sensing low perfusion. So the way I think about it, the body thinks it's in the desert somewhere, it thinks it's hemorrhaging to death, and its response is to retain fluid, retain filtered sodium, and retain water, and in combination that will expand the extracellular fluid volume compartment. So we have all these mechanisms, and they work really well for things like hemorrhage and volume depletion due to vomiting, diarrhea, what else? So it does not work well for chronic organ diseases like heart failure, liver disease like cirrhosis, or advanced chronic kidney disease. So that's where this maladaptive physiology is actually harmful, okay? And so if you can imagine, as you're diuresing a patient and putting them into net negative sodium balance, the baroreceptors in the kidney are going to sense potentially a drop in cardiac output or a drop in perfusion, and they will just retain sodium even more avidly than they were before. So what's going to happen when the body senses a decrease in effective circulating volume or drop in perfusion? So the body's going to increase sympathetic nervous system activity, and so the proximal tubule will more avidly retain sodium in response to sympathetic nerve activity. Also, renin will be secreted, and so renin and the downstream effects will lead to sodium retention, as well as AVP, vasopressin, or antidiuretic hormone will cause water retention. So essentially all our mechanisms for retaining sodium will be increased, as well as pure water. And also renin release is accentuated at the level of the macula densa, in the kidney. And so the way the macula densa senses sodium delivery at the distal part of the loop of Henle is through the sodium chloride cotransporter that is the sensitive transporter to loop diuretics. And so in the setting of a loop diuretic, the macula densa will sense very low sodium delivery at that segment. Therefore, it's going to send a signal just across the aisle to the juxtaglomerular cells to secrete lots of renin. So again, we are driving sympathetic nerve system activity, renin, and ADH AVP secretion to try and maintain extracellular fluid volume. But the body doesn't know that it's fluid overloaded. So remember that loop diuretics work at the ascending loop of Henle. And so just distal to that is the distal convoluted tubule. And remember that there are distal convoluted tubular cells that have a sodium chloride cotransporter, and this is where thiazide diuretics work. And so if you think about it, in general, if 25% of the filtered load of sodium was handled at the ascending loop of Henle, and if we absorbed about 67% of filtered sodium at the proximal tubule, very little sodium is reabsorbed at the distal convoluted tubule. Okay. However, what if we're blocking sodium reabsorption with loop diuretics? And if we do this chronically, and if sympathetic nerve system activity is increased and renin is up and the body's sensing low perfusion, well then the distal convoluted tubule becomes more important in regards to sodium retention. And so we actually see hypertrophy of these distal convoluted tubular cells. So look at what happened. The distal convoluted tubular cells have increased in size. Now they've put more transporters on the luminal membrane. Now we have more sodium chloride transporters. We can reabsorb more sodium chloride. They have more mitochondria inside, so they're more energetically active. And so from their perspective, they see now lots of sodium chloride delivery, more than they're used to. And so they look at this and say, wow, the loop of Henle is falling down on the job. They don't know that we're administering loop diuretics. And so they step up to the plate, they grow in size, and they do what they're told to do, which is reabsorb lots of sodium and chloride. So these are the main reasons why there's adaptation or resistance to loop diuretics and this breaking phenomenon. And so that's why our next step is to block sodium uptake at the distal convoluted tubule. So this is administering a thiazide-like diuretic that will block sodium chloride reabsorption at that sodium chloride cotransporter. And so for an inpatient, ill patient who is fluid overloaded, we use chlorothiazide, which is the IV thiazide diuretic. The brand name is Diuretic, and so the only reason I throw that on there is that I've recommended to a team to use chlorothiazide before, and they administered oral hydrochlorothiazide. So it's very specific to give chlorothiazide, which is IV, and so you can give this every 12 hours, and this usually works if there's diuretic resistance due to hypertrophy of the distal convoluted tubule cells. Metolazone is another excellent thiazide-like diuretic. It has a very long half-life, can be used maybe for the stable inpatient or on an outpatient basis. And then last but not least, let's say that you administered chlorothiazide and that did not work. You did not achieve net negative fluid balance. This is where we actually consider mechanical ultrafiltration or dialysis if there's concurrent renal failure. So typically I think this algorithm will work really well for helping you manage your patients. In general, as a nephrologist, we get a lot of consults for fluid overload with varying degrees of kidney injury, and usually once the patient has developed loop diuretic resistance or adaptation, we get called and asked to start dialysis at that point. But I usually don't want to even do that until we've done a trial of blocking sodium uptake at the distal convoluted tubule. In many cases, it works really well. And so this is something I really want you to take away from this, is that don't give up. Don't automatically jump to ultrafiltration or dialysis until you've also concurrently blocked sodium uptake at the distal convoluted tubule, in addition to blocking with the loop diuretic. So when you block sodium with the distal convoluted tubule, you're also co-administering the loop diuretic. So one final special situation, this is the patient who's developed fluid overload. They've been treated with loop diuretics for quite some time, and then they develop a metabolic alkalosis. So this is quite common, and this develops because distal sodium delivery to the collecting duct will result in enhanced proton excretion. And then also due to the perceived volume contraction, right, due to a decreased effective circulating volume, the proximal tubule will avidly reabsorb filtered bicarbonate as well. And so the patient can develop this metabolic alkalosis in response to heavy loop diuretic use. So the answer here is to add IV acetazolamide. So essentially what's happening, there's avid sodium bicarbonate reabsorption at the proximal tubule, and so this is generating the metabolic alkalosis. And so if the patient's still fluid overloaded and needs net negative fluid balance, you keep the loop diuretic going but add IV acetazolamide, and this will result in a net loss of sodium and bicarbonate, okay? And that will help correct the metabolic alkalosis, because you don't want to cause a second problem by trying to fix your first problem. And so this is sort of a special situation, but it frequently does develop, right? You may see a patient develop metabolic alkalosis from heavy IV loop diuretic use.